welcome. Thank you for coming. Everybody hear me okay? So my name is John Sather. I'm the Director of Quality Improvement for the Department of Emergency Medicine at Yale. Arjun Venkatesh is a scientist in our Center for Outcome Research and Evaluation and the Director of ED Safety and Quality Research Strategy. We're both going to be talking to you about our project. Not only are we proud of the project and the results, and we want to share that with you, but also we found it to be a tremendous sort of learning lesson as we went through the process, and I think we can share it with you and perhaps give you some thoughts about how to tackle a problem like this or a similar one. Some acknowledgements, disclosures. So we collected our data through support of Yale Center for Healthcare Innovation, Redesign, and Learning, otherwise known as CHIRAL. The research was supported by a grant, an ARC grant, and also some support from our hospital through the Claude D. Pepper grant. This work is our sole responsibility, and the views that we espouse and the disclosure for Arjun, he received support from the groups that you see there. So like many quality and safety problems, we didn't necessarily go looking for this. I think it found us. In 2010, our hospital developed a pretty robust inter-hospital or transfer center that streamlined inter-hospital acceptances and transfers. And I think like most institutions did that, had an idea to bring in more patients to their expertise that we can provide, but did not do so with a great understanding of sort of the burden and did not anticipate the high yield of critical care transfers. And that resulted, predictably, in some ED boarding of typically ICU patients who were accepted did not have an available ICU bed to go to and sit in our emergency department. I think fairly typical. Out of that bubbled up some increase in related QI cases, or just sort of a sentiment from our group that, hey, things aren't necessarily super safe down there when this is happening. So we perceive there may have been some safety and quality risks. It sort of culminated with a case just prior to the initiation of this work that I think is probably emblematic of a lot of our ICU transfers and represents, I think, the gravest of outcomes. So it caught our attention. It was a 60-year-old male who recently was in our institution with an aneurysm at a clip and a VP shunt. So well known to our neurosurgeons, but it came from fairly far away, so presented to an outside hospital on the day of his transfer with a slight facial droop and a small subarachnoid hemorrhage. Also had a little wall hematoma just proximal to the aneurysm. So the outside hospital saw this, called our general neurosurgeon who was on call, who said, sure, send it down to Yale. Patient underwent inter-hospital transfer to our ED. Blood pressure at the outside hospital was above 190 in a couple readings. Didn't receive any afterload management there. Got to our emergency department. There were no ICU beds, so we essentially immediately went into boarding mode. There really wasn't a diagnostic question. Patient stayed more than 6 hours in our emergency department. Blood pressure ranged over that time from a lowest systolic 170, but basically through much of the time systolic in the 90s to 200s and high diastolics. Was seen by our general neurologist, kind of when they got there, it's called neurology, and our general neurosurgical team, which is really the residents. Kind of a lot of back and forth about what kind of blood pressure parameters. None were really clearly defined for our practitioner. And over that entire time with those blood pressure readings, only one dose of labetalol was given during the entire ED stay without really a significant improvement in the blood pressure. Patient was finally transferred at about the time the patient was being transferred, not to our neurologic ICU because there were still no beds, but to our SICU. The patient became obtunded and there was an expansion of the bleed. Unfortunately arrested soon thereafter and died in the SICU. CAT scan at about the time of the resuscitation revealed a devastating expansion of the subarachnoid. So needless to say, we took someone who was neurologically intact, had a known diagnosis, and we had hours of opportunity both from the outside hospital through the inter-hospital transfer process in our ED to address this. We didn't, with a terrible outcome. The things that were really frustrating to everybody involved was that we have a neurointensive care team in the hospital at the time this patient was in our ED, so a neurointensivist, a neurointensive care fellow, who really wasn't aware that this patient was down in the ED, and the actual neurovascular surgeon who specializes in aneurysms, who had this patient as his own patient, was in the hospital, in the operating room, but not even aware that this patient was down in our ED. So obviously it caused a little bit of concern, and I think it went from a general one-off QI case review to, hey, is there a bigger problem here? And we looked at it in the context of the challenges we were perceiving with the inter-hospital transfer. And we wanted to look at that entire process, but when it involved so many different subspecialties, some patients were going to the MICU, the CTICU, the NICU, the cardiac intensive care unit, that it was such a heterogeneous pool, we were having trouble figuring out how we were going to approach the problem. And when we saw this case and some others related to it, we realized that what we call atraumatic head bleed would probably be a good target. And that's because of a couple features. First of all, it's a complex clinical entity with time-dependent interventions that most people can agree on, and time-dependent interventions that are achievable just pretty much by anybody regardless of location. These patients are subject to multi-specialty care, lots of touches with a result in, we think, diffusion and responsibility. These patients are frequently transferred. We're a tertiary center receiving many of our state's neurovascular emergencies, so we're seeing a lot of these. So we thought that the volume was high enough, but not so high that we couldn't tackle the problem, so it seemed like a good target. And then interestingly for us, and this is why we call it sort of the global head bleed, it's a vague diagnostic terminology. I think that prior to our work had challenged any kind of QI and safety focus. Most of the neurovascular surgeons think of aneurysmal subarachnoids, and most of the neurologists think of ICHs, but when these patients are undergoing inter-hospital transfer, we really don't know what it is. We're not sure. So to call it one or the other when we don't have all that data, I think leads to a lot of the problems. So we sort of rolled them all into what is much more of a clinically usable term of just atraumatic head bleed. So we found our target. We knew we had a couple QI cases. Those QI cases exposed, I think, some known safety threats that we could have just stopped there and worked on, but we really felt that this was a classic example of a latent safety threat kind of lying in the murks. And the question is, how are we going to dive down and figure some of that out in such a complex process? So we were lucky at the same time, CHIRAL, the Center for Healthcare Innovation, Redesign, and Learning that I mentioned before, was up and running through an AHRQ grant and really working as a patient safety learning laboratory. It was a joint venture between the School of Medicine and our hospital. And the goal was to understand and creatively solve complex patient safety issues relating transition and care. There's actually three arms of this overall project. One is transitions in, one is transitions within the in the hospital itself, and one is transitions out of the hospital. So we thought the transition into the hospital was a perfect match, and that's what we chose to focus on. It really gave us a unique opportunity to blend an important QI initiative with some research. I'm going to bring Arjun up to talk a little bit about the research end of it and then the results of our work. You want to mute this just while we're switching it, please? Thanks.
So the challenges that we perceived with this project and thinking about how to improve the safety of these transitions were the challenging terminology that John described. What do you call this disease? It's really a clinical syndrome in some ways. How do you dissect a complex inter-hospital transfer? How do you get stakeholders involved and engaged in the process? That means hearing all of their voices and getting them to buy in to doing care in a different way. And then there was a lot of limitations to using traditional quantitative methods to describe this. So if we had just used quantitative methods to say, oh, this is the percentage of time that we get blood pressure control, or the kind of basic chart review feedback you try to give, we felt we wouldn't have gotten to those latent safety threats that John described. And so our approach in the CHIRAL Center is to apply what's called the ADDIE model. It comes from the world of systems engineering and process engineering, and take that model and apply it to these complex healthcare processes. And so that starts with analysis, then design, development, implementation. It's very iterative in this sense, so you have multiple interventions, you're trying them at different times, just the way the engineers approach problems, and evaluating constantly. And so this falls within what I would call kind of the mixed methods world, of quality and implementation science. And so there's different kinds of mixed methods that you can have. One kind is called the convergent parallel design. That's at the top there. That's when you're doing quantitative and qualitative data collection at the same time. You merge the two together, and then you interpret the results. That's what we chose to do. And the reason we chose to do that is there were some things we knew we could measure quantitatively, but other things that we needed to measure qualitatively, and that we thought if we showed both kinds of data to people, they would respond better. You can understand why this happens if you've been in a quality director role, you're trying to guide docs. The reality is this. Doctors either think they're scientists, but often are not scientists. We're not very good with numbers. And so the reality is that half of us actually do respond to data. The other half of us probably respond better to narrative. And so our belief was that if we can show both kinds of data out there, you'll get what each person responds to engage them and buy it. So the first challenge was defining that patient population. We could have made our project really hard if we said that we had to define it the same way every time. But you've got to come up with multiple working definitions in order to make the implementation of a project work. And so you can see we did different types of projects to understand the current state of care. We did one traditional chart review. We pulled every patient that had an ICD-10 code that was based, that said the word subarachnoid hemorrhage, intercerebral hemorrhage, intracranial hemorrhage. But what we found is that 85% of the patients that had that code on their chart were not presenting with an acute atraumatic head bleed. Many of them had previous head bleeds, many of them had trauma, some of them had just cancer with a little bit of microhemorrhage. And so that wasn't a great way to find cases, but it was a great way to get chart data and actually look at performance on prior cases. We then did what's called a real-time survey. We had trained nursing research assistants hang out in the ED, and every time they heard that there was a new neurological patient, a stroke alert, or they heard that there was an ICH patient coming from transfer, they'd run over, and as soon as the patient got there, they would do surveys of clinicians, nurses, doctors, residents, you name it, from the point the patient arrived, including our triage nurse at the ambulance triage, to the first staff that took care of the patient, to the staff that was taking care of the patient when they finally were going up to the ICU, and then of the ICU staff upstairs. So they're surveying kind of longitudinally what's the experience of these patients in terms of the risk of the handoff, what information is known. Still quantitative, they're putting numbers to a lot of these answers, but it starts getting closer to being something more qualitative. We then did case-by-case evaluations where we would take registry reports that came out from both the neurosurgical and neurological services on patients that they'd identified, audit them and give feedback back. And then we have an automatic dashboard. And for that one, we created a machine learning algorithm to define how you find these patients. And so you see this mix that goes from quantitative to qualitative. There's different types of data that we got from each of these. The chart review tells you about how often are these patients coming, how often do they go directly to the ICU, how often do they come to the ED, what percentage of the time do we get blood pressure control, what percentage of the time are they getting anticoagulation reversal. We did audit and content analysis of the phone calls that happened between outside hospitals and us, listen to what people are talking about, how often do people ask about vital signs, ask about anti-epileptic drug therapy, ask about anticoagulation, and then how often do we give advice back if it's asked about. The survey, as I said, told us about provider perspectives. We did process mapping, so this comes from the Lean Six Sigma world, to really say what's every step and who all talks to who. It was this process map that probably, whenever it gets printed out, it's like 15 pages long, right? It probably goes wall to wall here. Before the intervention, it's like half as long now. And then semi-structured interviews to get ideas for improvement. Really ask people, what is your in-depth interview? We'd spend about 30 minutes with each of those interviews to try to understand what people were thinking about care. I put this up because a lot of people ask this. I'm describing a project that was done by a research grant. It involves many different research methods. Was this research? No. Our IRB actually said that this is quality improvement. And so all those different types of studies, they even said, fell under the quality improvement model because of the way that we were approaching this. And so the reason I bring this up is check what your local IRB says about what is and what isn't quality improvement. You'll find that many of them are fairly progressive on this. And IRB approval should not hold you back from doing a project. So what did we find from this? We did that chart review and we found that our time to anticoagulation reversal was 170 minutes. Time to giving the first antihypertensive drug, 54 minutes. When we listened to calls, what did we find? That 23% of the time we provided guidance on blood pressures, and every time it was asked for, but only 42% of the times were vitals even discussed on the calls between the sending hospital and us as the receiving hospital. What do we find in our real-time survey? Clinicians perceived that the handoff was inadequate 1 out of 5 times. The quote was, neurosurgery should have either reserve the bed in the NICU or block the transfers, what the ED attending said when there's no communication about what should have happened. Process mapping, we found out that there was tons of handoffs, you can imagine, between residents and attendings, between services, very little accountability at many times. And then in the interviews, we got a lot of quotes, and a lot of people responded to these quotes as we moved towards an intervention. Did you ever speak with the neurosurgeon or the neurologist who accepted the patient? The interviewee who's an ED attending said never. So we weren't having any attending to attending communication about these patients. If you're thinking about doing these projects, it's worth thinking about how much cost and time they take. So if you're going to do a chart review project, the cost is very low, the time is a lot. It took 2 residents almost 9 months to get through those charts. That's a long, long time. We had the liberty of doing this within a large grant and not a bunch of time for that grant, and so that helped. But I think that that's worth noting. The audit and content analysis doesn't give you as much information, and it can be a little more expensive because you got to figure out time of people to be able to get you the recordings, but it's pretty high yield. The real-time survey, we think, was probably the costliest and most time required project we did. It took paying for 2 research assistants to hang around ED. We only get about 30 of these cases a month, so there's only 1 or 2 patients to grab per day that they can enroll and follow through. Process mapping, very time intensive for those who have done it before. And then semi-structured interviews, probably the most time intensive of all the things we did, and costly because you have somebody to be able to go schedule time and meet with people and do those interviews. And so we made an intervention. Based on everything we learned from those, the intervention we designed was to provide statewide clinical guidance on blood pressure targets and a coagulation reversal, basically create a local clinical guideline for subarachnoid hemorrhage and for intracerebral hemorrhage. We then set up a new process where a patient was diagnosed at an outside hospital with an ICH or an SAH, and our transfer coordinator would request the community hospital to send imaging via life image, so electronically. No longer would a patient come with a CAT scan via CD. Reduces delays in care, ensures that we get complete transmission of data. Then we changed the process so that a surgeon would accept the patient and speak with that hospital, not any surgeon that was on call, but only 1 of 2 neurovascular surgeons, so the people that would actually be intervening on these patients eventually. At the same time in that call, then we would add the neurointensivist from the ICU on the call to speak with the neurosurgeon. So now 2 specialists are providing support and help to the sending hospital, and after that, that neurointensivist would speak to the ED attending. The ED attending would take that information. We created an electronic health record template in Epic for them to be able to enter it in Epic as a notification. So now there's complete accountability for information from the sending hospital to the ED with the specialist included and attending to attending conversation. And so when we started to evaluate this, in the same way we use both quantitative and qualitative methods. Quantitatively, we built a dashboard in the AMR. We did something in the middle, which I call case-by-case audit and feedback to providers on every case that came in. And then we also met with stakeholders and asked them what they thought in focus group type settings. What did we find? We found that we've reduced ED length of stay for these patients almost in half, from 300 minutes to 150. The time to admission dropped from an hour to 22 minutes. When you have attending to attending conversation, patients are known about and you can make plans, you can literally admit the patient that quickly when they arrive. Boarding time reduced for these patients, despite boarding getting worse in our entire emergency department over that time period. And we saw reductions in the amount of time that blood pressure treatment was ineffective, improvements in the time to reversal, and there was a mortality reduction, but I would say the study is not big enough or powered enough to really say that we saved that many lives. It might also be that we're also bringing in more transfers of less severe patients. Qualitatively, what did the quote say? This protocol provided me for quick care and disposition. I spoke to the ED before the patient arrived and asked them to initiate blood pressure control, so you're seeing that communication happening. It was helpful that both neuro and neurosurgical residents were there when the patient arrived, so that notification, early identification, and engagement. And so if you think about the yield versus the resources we put into this project, the yield of the statewide clinical guidance was modest. It took some resources to be able to get agreement. It's hard to get neurosurgeons and neurologists to agree on things. The enhanced image transfer didn't take much work for us, actually, because a lot of your shops probably do this for stroke, so doing it for an additional population is not hard. Improving the communication at the time of acceptance was the key. So we changed the entire call-in process of how you call, who talks to who, when they talk to each other, and what the expectations of what's going to happen on the phone from the time somebody calls an outside hospital to what happens here. That took the most time. It was single-handedly the biggest yield, I would say, in terms of impact. Our redesign of the EHR was easy, also had no impact. Not really. I mean, like, it's hard to use. People don't remember to do it all the time. That's not where the key information transfer is happening. And then, across some of these other things, I would say the other one that's kind of notable is that we moved to a protocol to auto-protocol CTs. So we created a world where you no longer, just like we do for an acute stroke patient, when a patient comes via transfer, they need a stat CTA. That vessel imaging guides whether or not they're immediately going to the operating room. And so we just said the expectation will be the same for this as we do for our acute stroke protocols. Patient arrives, they can be in the scanner in 15 minutes. This shows you how we laid this all out. Gantt charts are useful for this as well. You basically start with putting on where you have your initial baseline content analysis, but you can see within this that these were each of the interventions that we implemented. So people will say, oh, I did a multimodal intervention. It's fine to do that, but remember that if you use a systems engineering model, it's not going to be like a clinical trial. There's not one day that you started. And so the way we've analyzed this data is to say there was a period where we weren't doing any of this. There was a period of 6 months where we iteratively implemented different things and did different things, including one of which at the bottom there is a simulation project. So we actually simulated outside hospital calls through our transfer center and with our neurosurgeons and neurointensivists to practice talking through a patient. It sounds so juvenile, but in reality, I think they appreciated it. And in doing so, we worked through 4 or 5 kinks we hadn't even recognized in the process that we were allowed to subsequently fix so that come December here at the end, we're now in a full evaluation phase. We've really implemented all of these things, and we think we've worked through a lot of the kinks. And so I think the lessons learned are from a research side, audit and feedback can help you identify secondary challenges and remind staff of an intervention. So audit and feedback is good to know about what's our performance, but it's more valuable when people get that feedback and they can use it to change their practice. The second is that a small qualitative project can be very expensive in the unscheduled ED setting. And so it's potentially worth doing, but you have to pick your problems right for that. And then the last is that you may never get a universal denominator. So what you have to come up with is different working denominators that you can get people to agree upon and buy into. Operationally, a multidisciplinary team is obviously essential to work in this space. We found that the stakeholder sessions had greater turnout when we did it as a roadshow. So rather than trying to schedule in our modern world, a world where everybody has to get together once, it's almost impossible, we went to everybody else. So we went to a neurology faculty meeting. We went to a neurointensive care meeting. We went to neurosurgery grand rounds. We went to leadership meetings with each of these services. And then at the end, I will say this intervention, recently we had our joint commission visit for stroke center recertification, and we're a comprehensive stroke center. This was highlighted during that as something that was really unique across the country, they said. And so I think that your hospital will be happy if you do work in this space as well. And so our future work is to expand this to other non-neurological emergencies, continuously improve this through sustained performance assessment. We've got this automatic dashboard that allows us to track this now going forward. And then think about ways that technology could actually make this better. There's still a lot of human work within this process, and so if we can automate and eliminate some of those human steps, we think it can get smoother. All right. Thank you.
Like very resource heavy, and like thankfully you guys were funded, and it was also over like a 3-year period, which if I guess what would your advice be to somebody who is like starting out and wants to do this work in terms of like where to get the training and how to even like fathom trying to start to do such a thing, I guess.
Yeah, I think great question, and maybe I can speak to that because I'm more on the QI side, so I'm confronted with these problems all the time and don't necessarily have the research background or all the grant support. I was very fortunate to work with Arjun and CHIRAL on this project. I would say defining the scope of the project, so this worked because we took, I think, a high yield target. The numbers weren't huge. Everyone agrees that we need to do better with these patients. The second thing is the lesson we learned was I thought this was going to be something that was only of interest to the ED, and I think when you pick the target well and bring in the leadership from the other disciplines and get their buy-in, you suddenly get a little bit more resource support. And so our neurosurgeons, our neurovascular surgeons, really two, were just enthused, thrilled with this project, which I think if we had met with them initially, same with our neurointensivist, the chief of our neurocritical care division, so the two of them were so enthused by this and the target that it made it easy on a systems level to work with. I think there's no doubt, if I was to try to replicate this, say I wanted to tackle CT ICU transfers or something like that, or God forbid MICU transfers with such a big nebulous population, without some support it's going to be very hard. But I do think that those lessons learned, for me, having not done a lot of qualitative work to inform my QI initiatives. I would not do a project like this without doing that. It was so valuable, I think in particular the interviews, the semi-structured interviews, just going out and getting a sense of the pulse of what people were thinking really informed what we were doing. And when you go back to say, thanks, we heard you, now here's what we've designed, they're much more excited about complying. The process mapping we've done for a number of things, but that was crucial as well. And then, like so much of this, it's the IT support. Without the dashboard, the ability to quickly sort of provide audit and feedback, very hard to do, and we were fortunate to have, to ask for and have some, even beyond grant-supported IT support. We now have IT support in our operational division that can get us some of this data. But it is a challenge, and I don't know how I would tackle it without grant support.
Yeah. The one thing I would say is the grant support key was that we had one funded research associate who also functions as a project coordinator. That was the most critical part of the grant support. There was the in-kind support was the stuff that's kicked in, though. You'll find that when you work with other services, a lot of non-emergency services have these people they call as like nurse coordinators. And so they may not be researchers, and they may actually view themselves as part of the clinical program, but they have regular, ready access to doing some work for your project. And so if there's almost every one of these surgeons has some sort of nurse coordinator, and you can ask them for things like, oh, can you send me a list of every one of the patients that you have that do this? And they're actually looking in the charts of the vast majority of these patients, so they're willing to potentially do part of chart reviews and get you data like that you can get. The other type of resource I would say to kind of think about in the context of all this for training is, so the Institute for Healthcare Improvement has a couple great things. Obviously, they start with this thing called the Open School, but then they have a couple really good courses. I did one a couple years ago in Manchester. They offered in Boston a few times a year as well, which 4 days patient safety leadership learning, and that gets through a lot of the qualitative methods and the process re-improvement methods and things like that. And so there's ways you can kind of boot camp yourself up to learn a lot of those things. And then the last thing I was going to say in terms of kind of the resources it takes is that there's a business case for some of these projects. One of the reasons we chose this project was because the belief was that, and it's too early to say if it's true or not, that if we streamline the process and we make it better, it'll be better for sending doctors, and then sending doctors will want to send us more patients. And these are critically ill patients that require specialized services in the operating room are remarkably high margin. And so the other thing to do and not forget is that if what you're doing is actually going to generate revenue for the medical center, it's actually more important than reducing costs. It's really hard to show cost reduction. People are much more interested in revenue generation. And so always think first, does my project generate any potential revenue? And if it does, you'll get more support, more resources for it. Okay. Thanks.
All right, thank you.